Good morning, and welcome to this session on existing and novel topical treatments for atopic dermatitis. My name is Robert Bissonnette. I'm a dermatologist from Montreal, Canada. I consider myself very fortunate today because I think I have the most interesting subject of this one-day course, topical treatments for atopic dermatitis. There's a revolution coming in terms of topical treatment. I've been in practice for about 28 years, and I've seen how biologics and oral drugs change the way I treat atopic dermatitis in patients with other inflammatory skin diseases. You will see how those novel topical treatments would change the way you treat patients with AD and skin diseases like psoriasis and other inflammatory skin diseases. This is my conflict of interest slide. I'll be talking about several drugs today, some that are approved, some that are in clinical research, and I've been a consultant, an investigator, or received funding from most of these companies. Current topical treatments for atopic dermatitis. Now, I may not have the most interesting topic, but I definitely have the most practical topic because every patient with atopic dermatitis should receive a topical treatment. The first treatment they should receive is a moisturizer. And this is often the only treatment needed for patients with very mild to mild atopic dermatitis. It should be used every day. In fact, what I write on my scripts is to use it 5 to 10 times a day. I know patients won't use it 10 times a day, but it gives them a sense of how important it is to apply them on a regular basis and how innocuous the treatments are. Patients using moisturizers a few times a week obviously will not get a lot of improvement. Moisturizers have been typically divided in 3 classes: emollients, occlusive agents, and humectants. A few words about urea. So urea is a product that has been proven to be effective in atopic dermatitis. There's a Cochrane review on the efficacy of urea in AD. It is something that is fairly popular in Europe, specifically in Germany, not as much in North America. I've used it in my patient population in my practice. I've done trials as well with urea. And when you use low concentration, so 5% or less, it's usually fairly well tolerated, doesn't really burn, and can give some interesting improvements. Now, there's a need for research in terms of how emollient works. This study published by Emma Gutman's group a few years ago looked at comparing petrolatum to occlusion and found that petrolatum had an effect that was different than occlusion alone. It increased antimicrobial peptides production and barrier gene expression. So those moisturizers are not only there to put water on the skin or to prevent evaporation, they have other effects, and these should be studied. Now, how effective are moisturizers in AD? I'll show you a few pictures from a study we conducted about 10 years ago. This was a study conducted in kids between 3 to 12. They could not use any active treatment, no TCS, no steroids, no TCIs, only moisturizers. And this is what you can expect with 6 weeks of moisturizer. Another example, lesions on the breast with some very good improvement, probably moderate severity to almost clear. Another example of a moderate patient that is more on the severe side in terms of crusting, like an effication, you can get improvement. So obviously this patient needs more than a moisturizer, but a moisturizer alone can have a very interesting effect. In fact, when moisturizers are combined with TCS, you end up with this. And this is a study published 10 years ago now, looking at randomizing infants less than 12 months of age. All infants received micronized Bissonnette, but they were randomized to emollient or no emollient. And the group that was randomized to emollient used less topical corticosteroids. So not only are emollients effective, they can decrease the use of TCS. Now, TCS. So I will not review all the steroids today. You know this probably very well, and it's outside of the scope of that presentation. What can I tell you about TCS? I'll focus more on tips. So the problem with TCS is that patients are usually not using them the way they should. And atopic dermatitis patients specifically, they tend to underuse them. So if you have a new patient with AD, you really need to sit down and spend some time to explain how to use it. They need to use it. One possibility is to use the fingertip unit tip in order to tell patients how much they should use. So the fingertip unit is the amount of cream that is put in a linear way from the interphalangeal joint up to the tip of the finger. And this is equal more or less to about 0.5 grams, which covers between 1.5 to 2 pounds. So this can be used as an indicator to tell patients how much they should use. Now, obviously, you need to select the proper strength of topical corticosteroids according to body lesion. You should also consider maintenance therapy. So one issue with patients with TCS is often they use it, they gain control of a flare, and then they completely stop and use nothing. So what can be used when you get control of a flare? You could decrease the frequency of TCS application, you could increase the frequency of your moisturizer, or you could use a non-TCS as prevention. I'll talk about this a little later. Now, what about the patient to whom you or somebody else prescribed the TCS and comes back and say, it doesn't work, I need something else? Again, you need to sit down with this patient. I would suggest not asking closed questions such as, are you using your TCS twice a day on all your atopic dermatitis lesions? Because then you'll probably get a yes, and it's not really what patients are doing. I tend to favor open questions. So, okay, what are you using? Often we find out that they mixed up tubes and they're using the wrong tube at the wrong place. How frequently are you using it? Sometimes patients say it doesn't work, and you end up knowing that they use it twice a week, only a tiny amount on some lesions. Atopic dermatitis patients tend to not use enough TCS. Some patients even use homeopathic doses that will never work because they don't use enough. However, there are some TCS abusers. It's important to identify them. Those that use the wrong strength, they were given 2 tubes, and then they use the super potent topical corticosteroid or potent on their face. They're using a steroid given by somebody else. Or they're using TCS in order to prevent atopic dermatitis, which tends to, in my experience, induce significant skin atrophy. So you need to spend time with patients to understand what they do. Topical calcineurin inhibitors have been approved now about 20 years ago. I remember when they came to my practice, I thought, well, I'll stop using TCS. All my patients will be controlled by TCIs, and that will be the way I'll be treating atopic dermatitis. I still use them on a regular basis. Many of my patients are controlled with TCIs alone. Many use a combination of TCIs and TCS. However, it did not end up what I thought it would end up 20 years ago. Why? First, because those drugs tend to induce burning and stinging, and I'll give you some tips to try to avoid that. They have, I would say, moderate efficacy for atopic dermatitis on trunks and limbs, and sometimes it's not sufficient. And also, there's a famous black box warning of lymphoma and skin cancer that came into existence a few years after approval. There are 2 TCIs approved in the US, pimecrolimus and tacrolimus. Pimecrolimus, there's one formulation, the 1%, the cream formulation approved for adults and children 2 years and older. Tacrolimus, there's an ointment formulation, 0.03 and 0.1 approved in adults, and 0.03 for children aged 2 to 15 years. In other countries, like Canada, for example, some of those drugs, like pimecrolimus, are approved for children 3 months and older. It's not the case in the US. Now, this is a study published now about 20 years ago, pimecrolimus versus vehicle, children and adolescents. A few things about this slide that are very important to know. First is, with topical drugs, you can never compare 2 different studies. If it's not a head-to-head comparison, you cannot do a comparison. This is obviously true for anything in medicine, but it's especially true with topical treatments in atopic dermatitis, because the severity, the patient population often varies tremendously between one trial to another. And even the efficacy measures that are used today, the IGA 01 that are used today, are different from what was used 20 years ago. So what you see here, first is the vehicle works fairly well. So 20% almost of patients who are clear, almost clear, after day 43. More patients were cleared with pimecrolimus. It was statistically significant. This is a study we conducted with Gutman, published in JASI a few years ago. This has the advantage of being a study where the products were applied on site. We measured the amount of product that has been applied on site. We compared Elidel to vehicle, to betamethasone dipropionate, and to clobetasol. And what we found was an improvement that was statistically significant with the more potent steroids. Numerically, patients did better at 2 weeks using Elidel. It was not statistically significant. There was also extensive work being done in Gutman's lab in terms of gene expression. I'm showing only IL-13, which was significant with the steroids, but not with pimecrolimus, even though you see it's a little lower. So this is a, I would say, low to moderately effective topical treatment for atopic dermatitis. Tacrolimus efficacy expressed in a different way. So proportion of patients who are cleared or had excellent improvement. And what you see is that the 0.1% formulation, with that formulation, close to 40% of patients at week 12 had either excellent improvement or were cleared, and this was better than vehicle. Comparison between tacrolimus, the two concentrations in the hydrocortisone butyrate, there was no difference between the highest 0.1% concentration in hydrocortisone butyrate, suggesting efficacy of a moderate TCS. Head-to-head trial in adults and children with the tacrolimus 0.1, so not the 0.03, with the 0.1 and pimecrolimus, showing superior efficacy of the tacrolimus 0.1 as compared to pimecrolimus. Now, there are a few ways of using TCIs, and one way that I like, that I use in my patients, is to try to convince them to use them to prevent atopic dermatitis. Now, I must say that this is not approved in the US. In other countries, prevention of atopic dermatitis with TCIs is something that is in the product monograph, but it's not in the US. So classically, patients tend to use TCS when they have a flare, then they stop, then atopic dermatitis comes back, they use it again, then they stop. That's not ideal. They need to use something in between those flares. And one possibility is to start to treat the flare with TCS, and I should say, don't try to treat flares with TCIs. It doesn't work well. It has to be with TCS. Then you introduce the TCI, and you can think about using them twice or 3 times a week on the areas where patients always tend to have atopic dermatitis to prevent atopic dermatitis. This study, published in 2008, compared that proactive therapy to reactive therapy, where you just wait for the flare to come. And the study showed that you had fewer flares if you use proactive treatment with tacrolimus. Now, I mentioned before, there are some tolerance issues with tacrolimus, burning, stinging, puerbitis, erythema, for example. This study compared tacrolimus to pimecrolimus, showing more burning sensation with tacrolimus as compared to pimecrolimus. So tacrolimus 0.1% is more effective than pimecrolimus 1%, but tends to induce more burning sensation. This is also what I've seen in my practice. Now, this is a really important graph. When you give a prescription of TCIs, don't tell patients that that the burning sensation should go away the week. You need to tell them that it will take several weeks. What I tell my patients is, let's do a trial of about 6 weeks. Let's try it for 6 weeks. The burning sensation will progressively go down. So after a week, it will be less, but it's really in 6 weeks that you will see how good it is and how well you tolerate it. If you look at this graph, after 1 week, 25% of patients treated with 0.1 still had burning sensation. So it's not gone after a week, but it's better. What can you do to try to decrease that burning sensation? A few things. First, you can start with TCS. So in fact, I don't think you should ever start with TCI specifically if patients are flaring. You start with TCS, you control with TCS, and then you introduce the TCI. It's possible to put the tube in the refrigerator, possible to apply the moisturizer first and then the TCI after, and then reverse it eventually, or mix it with a moisturizer cream. Now, very important study published recently. Amy Poehler is the first author. This is the 10-year tacrolimus registry in atopic dermatitis. So this is a registry of patients with atopic dermatitis treated with topical tacrolimus for 10 years. 8,000 patients, more than 2,000 completed the study. They found a few cancers. The main reason why this was done is to study the incidence of cancer. There were a few cancers, as expected in children. However, the incidence ratio was exactly what was supposed to be observed in this patient population. In other words, there's no increase in cancer when patients are treated, kids are treated with topical tacrolimus for 10 years. Crisaborole, an agent that has been approved a few years ago. What you have on the left is PGA0 or IGA01, so patients who are clear or almost clear. In blue, patients randomized to crisaborole, and in orange, patients randomized to vehicle. You see the two studies. It's statistically significant. Again, the vehicle had a very strong effect. We always see this in atopic dermatitis trials, and it's not an issue of the investigators not being able to evaluate the lesions. It's just because these good vehicles are good treatments for atopic dermatitis. There was a statistically significant difference between the two groups. The delta is not very big, but it is statistically significant. One issue with crisaborole is it tends to burn and sting as well. Not as much as the TCIs in my experience, but still the same strategy should be used with patients. So it tends to burn more on the face. So on the face, don't try to use it for flares. Try to tell patients to do TCS at first and then introduce the crisaborole progressively. I think that's the best way to use this drug. It works very well for lesions that are not on the face. This study was published a few years ago, 2 years ago now in JASI. It's a collaboration with Emma Gutman again. What we did was we applied on-site on 80 areas outside the face, the neck and the genitals with trunk or limbs. We applied either the crisaborole or a vehicle. What we found was after only 1 day, patients were able to tell which side was treated with crisaborole. They were able to show a statistically significant improvement in pruritus on the side treated with active drug. After a week, this was also seen by physicians, and more important, after 15 days. Now, this is an important publication that came out in JAD last year by Zoe Dramos. What this group did was to work on abdominal skin and look at penetration of crisaborole when you either first apply crisaborole and the moisturizer later, or you apply the moisturizer first. And what they found was if you use crisaborole alone, or if you use crisaborole and then use a moisturizer, there's no big difference. These are the two curves that are in color. However, if you apply the moisturizer first and you apply crisaborole immediately after, then you have a decrease in about 75% of penetration. Even if you wait 15 minutes, you have a statistically significant decrease. So always tell your patients to apply the drug first and the moisturizer later. Now, what's in clinical development? Again, very exciting, numerous drugs in clinical development for atopic dermatitis. Topical JAKs, we have 3 oral JAKs that have been shown to be very effective for atopic dermatitis. Some have even been approved in some countries. Topical JAKs, we have topical ruxolitinib, a JAK 1 and 2, which is completed phase 3, and delgocitinib, a pan-JAK, which is approved in Japan. Topical ruxolitinib phase 3, PGA 2 or 3, BSA 3 to 20%. Patients randomized to 2 concentration of ruxolitinib versus vehicle. Let's look at week 8. Up to 53.8% of patients were clear or almost clear, as compared to a low placebo responder rate in those studies. Very fast onset of action on pruritus, as you can see on those graphs. These are the 2 studies. In gray, you have the vehicle, and in color, you have the 2 concentrations. Delgocitinib, I'll be showing you results of the Japanese study conducted in a patient population of 10 to 30%, modified EASI of 10. So this is more a systemic, I would say, type of population. Patients randomized to vehicle or delgocitinib. Primary endpoint was change from baseline in EASI. This was statistically significant. IGA 0/1 was statistically significant on the face. More difficult to get an IGA score 0/1 with a 2-grade decrease in a patient population of this severity for the entire body. Roflumilast, it's a PDE4 inhibitor, more potent in vitro than crisaborole. There's an oral formulation that is approved for COPD. It's currently in phase 3. I'll show you phase 2 data. 136 patients randomized to vehicle, 2 concentrations of roflumilast, mild to moderate AD, 1.5 to 35% PSA. What you see, primary endpoint was absolute change from baseline. There was a numerical difference between vehicle and roflumilast. However, it was not statistically significant. But when IGA 0/1 and a 2-grade decrease was looked at, it was statistically significant. Finally, tapinarof, an AHR modulating agent, a completely different mechanism of action. I was fortunate enough to conduct the first study with this agent in atopic dermatitis that was published in JAMA Dermatology years ago. It has been shown later to increase barrier gene expression, including filaggrin, increase IL-10, and decrease IL-17 in preclinical model. Phase 3 have been completed in psoriasis, so it will probably be approved in psoriasis first, and it's currently in phase 3 for atopic dermatitis. Phase 2, sorry, yes, phase 3 for atopic dermatitis, and I'll be showing you the phase 2 data. 6 groups, 2 vehicles, and 4 groups with tapinarof. What you see here on the left is IgA clear, almost clear. If you focus on week 8, you see that the 1% formulation was superior to vehicle when applied once a day or twice a day. And this is the formulation that is currently being studied in phase 3. Now, my last slide, I talked about many, many things, but there are many, many more things that I couldn't talk about. There's a lot of exciting activity in atopic dermatitis with new topical agents and new topical ways of treating patients. Several groups, including Richard Gallo, is interested in microbiome, how we can change the microbiome, how we can treat patients with certain bacteria in order to improve atopic dermatitis. More to come. Thank you.